All right. Let's see. My name is Sichen. I'm one of the ID fellows on this way to Psych Conference.
You may, this is a micro, so you may want to just speak up a little bit.
Got it. Okay, so we have an 82-year-old male with history of diabetes, to CKD3, came in here for left leg pain about 6 weeks, and that is what happened. So 6 weeks ago, the pain kind of began, and the swelling began actually at the dorsum of his left foot. Nothing really happened. There's no like particular trigger to that as well. And then he went to the ED after it's not getting better. So they actually thought that it might be gout. So he was given steroids and colchicine and some naproxen as needed. But the symptoms actually did not resolve, and the pain actually extended up to the ankle, and then actually went on that later. And then 4 weeks ago, he went to urgent care, and then they did an ultrasound that looked for DVT, and that was negative. And so he was diagnosed with cellulitis, and he was given augmented about 5 days. You know, unsurprisingly, the pain and swelling basically did not resolve with augmented, and then now it actually has worsened and continued to ascend up to the mid calf, and that is what really brought him in to the ED. He actually denies any fever or chills or any open wounds, and again, no trauma whatsoever. So this is his past medical history. His diabetes, A1C is 7.3. He has AFib, sick sinus syndrome, got a pacemaker. HFrEF is really questionable there, but CKD3. Social history-wise, he's retired accountant. He's fairly independent. He loves to garden. And he walks in the park with his dog, but really like nothing spectacular, like rock climbing or hiking to an extensive extent. And the diet, he's everything, enjoys sushi, some oysters or whatnot, but nothing too particularly exciting as well, but does enjoy life. Not sexually active, no travel history, no international travels. He lives around the DMV area, and family history is really non-contributory. I also just want to add that he has no history of any kind of like recurrent infections in the past, nor really significant infection history period. Okay, physical exam. He came in here, his temp was 37.7. Heart rate is a little bit high, so it's his blood pressure, but his left leg just, in conclusion, just looks like there's a cellulitic picture there. It's like some mid 2+ pitting edema from the left foot to mid shin, very tender to palpation, especially over the dorsum of the foot, as noted earlier, but no gross abnormality, no skin breakdowns, it is warm to touch. That's pretty much it. Otherwise, he's well developed, non-toxic appearing. Everything else looked pretty darn good. Then we have these images. So the ED took a CT of the CT scan. On the right side, my right side, your right side. Also, this shows that there's an abscess there, and I just want to play this really quick regarding, I don't know if you can see well over Zoom, but basically an abscess right here. Okay. All right, and now we move on to labs. He does exhibit a neutrophilic predominant leukocytosis, no EOs. Hemoglobin is low at 8.3. Platelets is okay at 180. Otherwise, a little bit kalemic, hyperkalemic at like 5.2, just a little bit high. And then his creatinine is actually 2.8, up from baseline of 1.8. Glucose is 225. Okay, so he was admitted, blood culture was obtained, he was started on broad spectrum antibiotics and plastic surgery, took the patient to the OR, and they said that there was extensive tendon and muscle involvement, and there was pus everywhere. So in summary, we have an 82-year-old type 2 diabetes, came in here for an abscess of 6 weeks that is unresponsive to augmented. And we ask for your differential, and I'll stop sharing.
Okay, wonderful, thank you.
Oh, sorry.
Take a look here. let's see. Let's see. Valeria, are you on? Are you able to give us a few thoughts on what might be causing this man's apparent abscess?
Yeah, good morning, everyone. I'm not sure if you can see me, but can you hear me?
Yeah, just fine. Thank you
Okay.
so much.
Okay, excellent. So I think I was trying to think whether this could be a hematogenous spread versus local spread from the skin, and it didn't sound like the patient had any trauma, or at least that the patient was aware. So for hematogenous spread, I didn't hear any particular source of infection with bacteremia, but at age 82, we can think of maybe perhaps oral, anything from the oral cavity, so strep that could have caused bacteremia, and the patient is at high risk for bloodstream infections with his pacemaker, but it doesn't sound like he's had any symptoms that could point towards that. But still bacteremia, and then bacteria seeding at a distant site. And I couldn't really tell from the MRI whether there was like the abscess was within the muscle, or it was kind of like, sitting on the muscles. But anyhow, so other things would be staph aureus, or coagulative staph, and then perhaps some gram negatives from urinary source. Again, I did not hear any particular symptoms suggesting prostatitis or cystitis, but that would be another potential source for a man of advanced age. I think for local spread, I mean, those same organisms would be things that live on the skin. So I don't think I would add anything else there. You did mention gardening, and so I was thinking about Sporodrix schenki. I think typically you would see more nodules on physical exam, which you didn't mention. And it really did seem like cellulitis on exam. Let's see. Natasha, feel free to add if you see other things coming through the chat. So he has CKD and he has diabetes. So, could that put him at risk for other fungal infections? And I think it would be unusual for like something like Aspergillus, and I don't think it fits like a Candida infection. And then other fungi, I think it would be really unusual for this to be something like, a histo. But my colleagues from transplant can, maybe they've seen something like this. So I think I'm going to stop there. I never give very extensive differentials, but I'll stop there. Is it on the board, or should I keep looking for other things?
That's great, Valeria. Well, let's just open it up, and then we'll see if Sichen says we're close or on target here. Natasha, you added Clostridium species.
So Bill added
anaerobic kind of mixed infection, maybe.
Yeah, I think Bill added
Vibrio.
Clostridium secondary to colon cancer potentially.
Yeah.
Okay, yeah, and Vibrio maybe, but I think on exam it would be more like violaceous and more necrosis. But you did mention the oyster thing, so.
Catherine is adding nocardia, and Sonia's adding NTM.
TMs, yeah, I like that.
Yeah, I mean, this gentleman wasn't really he didn't have a lot of systemic features, right? I mean, he clearly had some tachycardia and so on, but didn't have fevers, right? But he did have some warmth, so you couldn't really call it a cold abscess, right? I mean, he had
It's
some
not a
local
cool
warmth.
access at all.
Yeah, but he
Correct.
was not systemically ill. Yeah, so Vibrio and plus, tend to be sicker patients. Any other comments from here?
Not yet.
Mhm.
Great list.
It's up there.
It's up there.
Okay.
Excellent. We're
Yay.
on the mark.
Great.
Okay. So
Thank you.
I'm going to have, thank you, Valeria. And I'm going to have Michael Mealy is assembling our online poll, but you, because you come in person, we're going to take the old fashioned hand count and see what people like here while that poll is ongoing. But Michael, why don't you, you want to say anything at this point? The poll, when the poll is up?
Yeah, just one moment. I'm just consolidating to try to get it to 10 choices. So just one moment. But you can proceed, Paul.
Okay, thanks. All right. Anyone like any streptococcus? You get anyone here? This is a nice one. If you want a lot of bang for your vote. No? Okay. What about Staph aureus? All right, there's a few MRSA, people that love MRSA. Okay. And guess what? They work in the hospital. Strange. Okay, coagulase negative staph, any kind here. Leukodensis probably. What about a gram negative? I mean, that's a category that covers a lot of grams. Anybody want it? No one. All right. What about Clostridia or, sort of this anaerobe mixed infection process here? Doesn't really look like it's fitting a real NetFash kind of problem. Vibrio. Anyone intrigued by the oysters? No? No? Okay. So of course, we don't know the time of year, so we don't know it. But you can get oysters year round now. Nocardia. We got 5. Nocardia is a hot one here. What about an NTM? Sportrix? Anyone? Is he a rose grower or does he use a lot of peat moss?
He does not discriminate.
All
All kind of stuff. I have no idea.
right, what about the mold Aspergillus? Candida? Anyone think this could be a Candida abscess, which can occur sometimes? Pisto. And I know there were a couple of processes there, but I think we were probably focused on the pathogen. Okay. Well, Nocardia was a favorite. Michael, how did the polling go?
We will end here, Paul, and let's see. We had, I think, a range of different of choices. No huge predominating. I did have to consolidate a couple, but we had, I think in the lead was a combination of either Nocardia or NTM, but even that only got 27% of the vote. And then we had staph species at 23%, Vibrio got 4 votes at 18%, strep then had 3 votes, and then a couple for Clostridium or Sporotrix. So a range of possibilities being considered by the group here.
Okay, great. Well, wonderful. Sean, tell us how this turned out.
Sure. All right. So the next one is Nocardia. So you
See,
guys-
this is a genius of coming to the room here.
All right. So
Overwhelming
basically,
favorite.
yeah. So the gram stayed positive, but not gram positive, and they were able to grow the culture, and then it is identified as moldy top. Just for I guess the applicants, that are here virtually. I just put in a slide, just to go over really quick. Aerobic, Nocardia is aerobic as opposed to actinomyces like cousin, which is anaerobic. Gram-positive BD filamentous branching rod that's partially acid positive. Like when we're studying, I think in med school or in residency, we talk about Nocardia as like kind of a whole, but there's actually 40 species that are actually considered clinically relevant. In the US, Nova and also Brasiliensis are probably like the top and probably around the world as well. All right, and then pathogenesis usually through inhalation, direct inoculation, or ingestion. as well. So, all right, so getting rid of that. So some of the clinical picture, we usually see, these patients in immunocompromised hosts, and that's what we usually are associated with them with. It's particularly, they are controlled by T cells. So HIV/AIDS, transplant, or any kind of like T cell depletion therapies. On top of that, they also have TNF alpha immunotherapies, and also rituximab are all related to that as well, CGD. Can disseminate to any organ, lung, brain. It loves the brain, it goes through the lung, loves the brain. So, and then also skin as well. The main manifestation we usually learn is like, oh, pulmonary, CNS, but it's actually, there's a cutaneous manifestation as well. And that mainly happens in an immunocompetent patient or host. And that's actually something I thought was very interesting. And I want to point out that about 1/3 of the patients that are infected with nocardia in general, not sure, are actually immunocompetent, which is kind of like this patient. I do know that this patient also has diabetes and CKD3. All right, so cutaneous nocardiadosis, it has like 4 manifestations or like 4 processes. One is superficial skin infection. This is usually has abscess, cellulitic pictures. They were noting that if you have cellulitis, just plain cellulitis or nocardia, it is actually not associated with any kind of bone and muscle involvement. But abscess is a different story. It could also look like sporicix. As you can see right here on the bottom left side, it would actually go up the lymphatics and have nodular presentations along that. So the third one is mycetoma, and the fourth one is secondary cutaneous involvement from disseminated disease. Okay, so we're going to talk about the primary cutaneous nocardosis, which is kind of the first 3 we talked about. Is it through a direct inoculations? It usually happens through people who gardens, who got into a car accident, had like some abrasions. There's a case reports with that. There's also some people get it from their cats, cat scratch as well. And it's mainly attributed by this nocardia brasiliensis that actually makes up about 80% of the known cases so far in the literature. And the most common manifestation is actually pus. It is slightly bigger than your staphylococcus folliculitis, and it's pus filled, which is quite interesting. And then I just also want to, they're also often ulcerated as well. They, as you can see, this is probably beginning to ulcerate. And if you want to like Google it, there's a lot of pictures that just showing like pus with ulcerations. And so we talked about the sporicix like presentation. I'm going to move on to the mycetoma. It actually has another name called Madura foot. It's actually, this is depicted as a New England Journal of Medicine case report that has pretty good pictures. It develops over the weeks and months. It's actually quite indolent. Mycetoma itself, or Madura foot itself, could be caused by a couple of different things. Like big categories are whether or not it could be from fungal infections or filamentous bacteria infections. If it's fungal, and there's no way to really tell, except for like you see under microscope, it's called eumycetoma. But otherwise, it's called acetylmycetoma. Notice that I actually said filamentous bacteria because it's not just nocardia that causes it, but streptomyces, and there's another filamentous bacteria called Actinomadura as well. Okay. So it presents with granuloma and also sinuses. If you Google this image, the New England Journal pictures here looks quite nice, but there are much more nastier ones that requires like much more extensive surgery for cure. But if it's not fungal, usually if you give them medication and antibiotics, they will actually do quite well, and they will actually heal by itself. Okay, so talking about like diagnosis and treatment. So we need, the golden standard is a culture, as expectedly, but we also need to know the species. There's like so many species, and they actually have variable sensitivities to the antibiotics, and you should always be guided by your antibiotic sensitivities. So, but once someone who is immunocompetent and they have a cutaneous involvement, you should always like rule out disseminated disease, usually with a chest X-ray or MRI of the brain to rule out there's no infection anywhere else. Bactrim is the mainstay of treatment, but Davidson et al. Back in 2020 said linezolid actually do quite well. This is a little bit small, but if you look at Bactrim right here, TMP SMX, some of the species and actually has variable sensitivity rate. But if you look at the linezolid, it's actually sensitive to every single one of them. And this chart is actually cut off because I couldn't, like, where else it would be too wide. But across all species of Nocardia that are clinically relevant, the sensitivity for linezolid is 100%. So in this Davidson paper, they reviewed about 20, this is a retrospective review. They looked at 28 patients. 20 went on to like linezolid containing regimens. 8 are Bactrims only. Now, I want to note that the linezolid containing regimen actually has Bactrim in it. And then they actually said that, on average, the induction therapy for linezolid is about 28 days retrospectively. And they said that they actually observed that it is actually within this 20 patients that had linezolid containing regimens, Bactrim was actually the cause of therapy discontinuation. So around like 40% versus like the ones that don't have linezolid, it's like 20%. But again, we're working with a small n, but they said that usually linezolid works a little bit better, at least that's what they suggest, than Bactrim. And this is according to the transplant guidelines. So what do you do when you have, primary or not a primary skin infection or stable pulmonary infection? You use Bactrim or linezolid, and then if it's mild and localized, you use monotherapy. One drug is totally fine. But if it's like disseminated or severe, you want to use 2 or more drugs. Again, this is guided by your Nocardia species and its sensitivities. Okay, moving on. So we talked about linezolid. That's great. On the Davidson study, they were saying, oh, there's strong cytopenia, anemia associated with it, which is actually not too surprising. So now the question is, what about tedizolid? So there's a in vitro study that's by this group right here back in 2017 that showed tedizolid actually showed pretty good MIC against some of the, I guess, less clinically representative species, but for Bacilliensis and Nova, which was like the top 2 species, about the same as linezolid. But people have been trying out this particular therapy. There's about 4 reported case reports. They were saying 1 tedizolid plus Bactrim for 6 months. They tolerated pretty well. There's no thrombocytopenia or any kind of like or anemia. Other 3 actually are switched from linezolid-based therapy to tedizolid for 6 to 10 months, and they have done pretty well as well. But again, there's strong reporting bias in these case reports. We just don't know whether or not, the unsuccessful ones, like how many unsuccessful cases there are, 1, and 2, tedizolid is extremely expensive. So we should only really reserve it for like the last drug of choice. So back to our patient. So we got a chest X-ray that was negative, MRI was negative, blood culture was actually negative as well. We started on imipenem and Celastin to start out with because the patient is in AKI and we did not have minocycline in the hospital. So we're just like, okay, this patient's old, maybe we could do like imipenem, and then it's a course of switching Bactrim when kidney function actually improves later on. Initially, we'll do like a 6 weeks course, and there might be a possibility of adding linezolid in there, but his his hemoglobin is also kind of low. So that's pretty much it. Do we have any questions?
Yeah, wonderful. I think, and Michael is quite knowledgeable about nocardia, but regarding the carbapenems and the tetracyclines, I don't think you can really substitute another tetracycline for the minocycline, for example. And similarly, other carbapenems for the imipenem. Apparently, that doesn't wash so well, at least on in vitro susceptibility.
That's good to
That'd
know.
be a natural conclusion, I think. Am I on the mark, Michael?
That's right, Paul, as you said.
Do you have any comments, or Valeria? It's, this was quite a slow and extensive process, but it doesn't look like it involved its hardware or anything like this.
No. It really, there wasn't any signs of that. No.
Okay, all right.
I think, nicely summarized here by Sichen. Thank you for the presentation. I think it just highlights the, the way in which susceptibilities for different nocardia species varies quite dramatically, right? With macrolides not necessarily being a workhorse, for example, but, almost all nocardia nova isolates are susceptible to macrolides as an example, but also uniformly to trim sulfa and linaclid, as you said. Almost none, as you showed, Sichen, are susceptible to amoxiclav, perhaps providing the explanation for why he did not have any response to that agent. So always need to go to the expected susceptibilities for each organism while you're waiting for those specific data for each isolate, given the variability between species.
Clarification.
Yeah, thanks so much for those comments. And well, that brings us to our conclusion. We'll, of course, have a presentation next week that will also include pediatric cases. I think will be in the month of October. And really thank you all for joining, and hopefully you have a great day. And also to our candidates, that you have a good virtual day here at Hopkins. Thanks so much.